morning, everyone in Medical Alley. My name's Dawes Sutton, and I help support our partner engagement within the organization. Thank you guys for choosing to spend an hour of your morning with us to discuss a very relevant and popular topic at the moment, innovation in pre-hospital care. If you're here today, you probably know that this topic is revolutionizing the healthcare industry. So today we look forward to exploring the different aspects of pre-hospital care and hearing from our panel of experts who will share their thoughts, experiences, and expertise. But before I hand it over, I'd like to thank Lee Branding for their support. These webinars are made possible because Lee Branding invested in Medical Alley as a sponsor of our webinar series. So before we get started, let's learn a little bit more about Lee Branding. Well, thank you once again, Lee Branding, for your generous sponsorship. I'll quickly note that there are other sponsorship opportunities available. So if your company would like to learn more about building your brand in Medical Alley while supporting our mission to activate and amplify healthcare transformation, please reach out to any one of us at Medical Alley or send an email to info@medicalalley.org. I do also want to note that we will have a Q&A function for this webinar, as well as it will be recorded and distributed afterwards. With that, I'd like to hand it over to our panelists to introduce themselves and to the organizations they work for. Greg, would you like to introduce yourself first?
Yeah, sure. Thank you for the opportunity to speak with other great leaders of the industry. My name is Greg Howard. I am a paramedic by trade. I got started in EMS about 30 years ago working at a funeral home, worked at a various number of organizations, fire EMS. I taught at the university, site evaluator for National Registry, all the typical paramedic education stuff. Spent the last 15 years on a helicopter flying in Western Pennsylvania as a flight medic, and all along I worked for a software company, now ZOLL Data, so that's my disclaimer, selling software into hospitals and EMS and fire, government, etc. Thank you for having me.
Certainly. Nick, would you like to go next?
Sure, I'm Nick Simpson. I'm the Chief Medical Director of Hennepin EMS in Minneapolis, Minnesota. And I moved to Minnesota back in 2011 for residency and then did my fellowship training right after that. And took over as the Chief Medical Director in 2020. And since then, we've been on a quest to innovate as many ways as we can at Hennepin. And so that's me.
Perfect. Thank you, Nick. And finally, Kolby.
Hi, Dawes. Thanks for the invite. And I'm Kolby Kolbet. I'm the Chief Clinical Officer at Lifelink 3. Been here since 2013 and have about 20 years in air medical space and neonatal and pediatric ICU experience, as well as paramedic. So Lifelink 3 joined Medical Alley 2 years ago. And really our quest was to continue to innovate and look at how we can bring tertiary care medicine into the field. And Lifelink 3 considers ourselves early adopters of new technology. And, that includes doing research on the use of ultrasound back in 2007, jointly with Hennepin Medical Center. And that was published. It was the first of its kind published in this space. And it took until 2016 before we actually were able to implement it based on the size of the equipment. But that was based on feedback that we had provided based on that research. So it's Minnesota proud, really, when it comes down to finding ways to be innovative like our major health systems in the state are. What I found is that there's a lot of neat devices that maybe are made to be used in the hospital setting. One of those was BIS monitoring for monitoring patients under sedation, but we just couldn't make it work from a size and weight ratio in the aircraft. So it sparked a lot of conversations between us and medical device manufacturers And other devices have captured our attention to solve problems that we have every day, like non-invasive core temperature monitoring. And we thought this would be the conduit to get in front of key leaders in the medical tech space, medical device space, and help us meet the needs of our rural health folks.
That's terrific work. And I think maybe it would be helpful for people that don't know as much about pre-hospital care to learn a little bit more about that from not only the air support, but also the ground support too, that Nick helps lead.
Yeah, so I love to describe EMS. So if you go to ems.gov, you can click on a link that says, what is EMS? And there's a great graphic there that it used to show a sort of a pyramid, and there were 3 points on this triangle, and in the middle was EMS, and on the 3 points were healthcare, public safety, and public health. And in a post-COVID world, it's now a square, and there's 4 corners, and at the confluence of public safety, public health, healthcare, and now emergency management is right where EMS fits. So I think the really cool thing about EMS to me, and where I found that I think we are ripe for innovation, is that we touch a lot of different aspects of many different systems. We, you know, in our work at Hennepin, we end up talking with social workers and the ICU docs and the ER docs and firefighters, police officers, air care. And so it really is kind of every different aspect of people. And that's what I love about it. I don't know, Kolby or Greg, what would you guys add?
We become the conduit for rural health. You know, from Nick's experience, you know, he's with Hennepin Health, that's one sector of EMS, which is urban. And then there's rural and super rural areas that may have a volunteer ambulance service, you know, and there might not be another ambulance service for 80 miles. And it's held up by volunteers. And, you know, sadly, they have to do fundraising sometimes just to make ends meet. And oftentimes there's a subsidy or you know, where the county or city or municipality will help fund that. There's more and more responsibility falling on EMS to meet the needs of rural healthcare, and we're finding that EMS is the Swiss Army knife that's often forgotten about when it comes time to be included in public safety for funding and so on. What we're finding out in rural healthcare across the country. Currently, I'm the board chair for the Association of Air Medical Services, and we met with a group of leaders yesterday. And you know, this is a challenge throughout. Volunteerism is down for ground EMS. Funding and reimbursement, reimbursement is a challenge across the board, whether it's ground or air EMS. But you know, the vehicles that, whether it's ground or air, we're filling the void of rural hospital closures or loss of services. And we're either bringing the expertise to the bedside or to the field to initiate that tertiary care. We're an extension of our facilities, and we're bringing those patients to destination education or destination medicine centers so we can initiate that care early and have seamless continuum of care.
It's terrific. And I think
Yeah, I'd like to add to that. There's a lot of different models here. You have a hospital-based system where you have kind of hospital regulations and compliance, things like JACO, DMV, and then the community medicine, which may not have those strictest regulations. And there's two different worlds kind of need to intersect. And a lot of times EMS is the kind of the afterthought when it comes to innovation, technology, and even things like meaningful use money. So there's like HIEs and RIOs that money was gobbled up, and then now post meaningful use, there's not a lot of money, and EMS data is kind of that void of data. But overall, the things that the basic or the paramedic can do before the patient gets to the hospital can significantly impact that patient stay in the hospital. And that is even things like reintroducing non-urgent medications. So for example, like Lasix or steroids. So even though as a paramedic, giving Lasix doesn't really have a therapeutic effect for a while, or even steroids, but in the sense of hospitals and overcrowding and wait times, if that patient has to stay in the hallway, that medication has a time to take in effect, so that by the time it gets to someone like Dr. Simpson, then it's already therapeutic. And ultimately that might keep a patient off a ventilator, it might take them off an ICU day. And that's where we need to kind of bring together the data between EMS and hospitals to educate people that, hey, some of the things the EMS does really can change the burden of healthcare in a system or healthcare alone.
Yeah, it might be helpful for Dr. Simpson to walk us through kind of, because when a call to 911 comes in, some of those efforts begin on the phone call. And then, Nick, if you can talk about that transition to 911 and then, how the whole gamut of an interfacility or a scene request for an aircraft and how that's made. And then we can talk about interfacility transport.
Absolutely. Yeah. And, it's great. We take a lot of community leaders and elected officials out on ride-alongs, and we talk through this process with them. And I think it's often eye-opening as to the complexity of the systems that are at play. I mean, it's not quite as simple as you call 911 and then there's one person on the other end that will notify an ambulance, fire truck, police car to go to your location. There are a lot of computer systems, there's a lot of technology in place to make that happen. And a lot of those things happen simultaneously, which I think is also eye-opening to folks. And so in busy urban centers, like the one that I typically work at, that is the case where you will call 911 and then that call will be initially handled by that sort of primary public safety or answering point call taker. And then they will determine if they need to send it to fire or EMS. And where we are, like a lot of places, police is the sort of call taker primary source. And then they will get shared. And those things are often shared electronically with us so that as soon as they understand this is a call for someone that's having shortness of breath, that will immediately get sent to the fire dispatchers and EMS dispatchers. And then at all the same time, you get the appropriate number of units sent to that location. So we really strive to get the right resources to the right patient at the right time. And so that's sort of the very basics of how a 911 call works. And so interfacility transport can be done a number of different ways. There's the scheduled interfacility transport, which is probably, so it's not something that my organization does. And I would imagine that LifeLink does fewer of these, but the emergency unscheduled transports, those are where I operate, and I think where Kolby operates as well. And that is, someone that needs to be sent from one facility to another without any notice, but it needs to happen right now. And often these are very critical patients. And Kolby, you can certainly speak to that more.
Yeah, I think the most critical aspect of EMS that often gets not considered is you call 911 or you need help and help shows up. And it shows up fairly quickly. And one of the reasons it shows up is that all EMS entities show up without understanding who the patient is or who their payer is. And that's just what we do. We respond with the same level of effort and urgency as someone that's got private insurance as someone that doesn't, because we just don't know. And but from the time of call to the time of the aircraft leaving the ground is typically around 12 minutes. Once a ground EMS agency is, on the scene of an accident, or based on what the county dispatch, the county police station, usually a sheriff's department, receives a call for help based on the mechanism of injury, like, a fall from 30 feet, or a rollover with injuries or an entrapment. Some of those are key indicators for automatically launching the helicopter, just because they know that resources are going to be there's going to be a lack of resources in that area. So that's the scene aspect. And then the nice thing about what we do there is we're bringing the tertiary care to the bedside. And there's minimum equipment lists that you need to have on aircraft to satisfy the state EMS regulatory board, just like on ground. But for critical care, there really is no standard that's established and regulated. So it's really upon the ethos of the providers to determine that level of care. And LifeLink being a consortium member or a consortium owned entity of 10 health systems, 8 of them in Minnesota. It's like Greg mentioned, the more effort and the more we bring to that bedside out in the field and begin that tertiary level care, we hope to reduce the number of days in the ICU, or we hope to reduce the instance of ventilator-acquired pneumonia if we place a breathing tube and such. So certain things like that come with an investment, and that investment is above and beyond what reimbursement offers. So there's a flat rate for EMS, whether it's ground or air. You get a response charge or a liftoff in the air, and you get a mileage fee. And that mileage fee is only loaded miles. So if you go to a patient and you're not needed, or the patient expires, or you treat and release them or treat and transfer them by ground, that's an unbillable occurrence for that. So what we have done is stepped up, and we carry blood and blood products. And I see Jed Gorland's on this call, and he was instrumental helping us identify that blood was safe to give. We currently carry whole blood and in plasma on every flight. So there's no incentive to do that, but we know it's the right thing to do for the patient. We know it's a benefit to all of our hospitals. Ultrasound, I know that several ground agencies carry it, including Hennepin, and that's our magical set of eyes to help determine if there's bleeding or not bleeding, and if the heart's working effectively. And those are all pieces of cogs of the wheel, if you will, that makes things more efficient on the front end. So when there's a relationship in those emergency departments, and the receiving trauma team or the medical team treating that patient in the emergency department has an established rapport with these EMS providers, and there's a high level of trust there. So much more efficient, but costly. So the other thing I was going to talk about was with cardiac arrest in Minnesota. Anyone in Minnesota needs to give themselves a round of applause right now, because we are the leaders in management of cardiac arrest. And one of those things, almost every ground ambulance and air ambulance carries a Lucas device. And that is an external mechanical CPR device, and it allows the provider to be hands-free. And what that does is revolutionizes effective CPR. And what makes it a great system is that in Minnesota, those patients will go to the cath lab, they'll go to intervention, and they may even get ECMO. And for ECMO, that's basically, for the layperson, that's cardiac lung bypass, heart-lung bypass. And it allows the heart to heal. And for those, when the patient goes to the cath lab, that's the stent placement. And oftentimes, if you leave the borders of Minnesota, it's rare to see a system like that, where everyone's on the same page and the expectations and the standards are set and commonly understood across systems.
I imagine this has a huge also impact on the movement of data, which I'm sure Greg can speak to a little bit more, whether that be the security aspect, those that are blockers to it, et cetera. Greg, are you able to expand a little bit more on that?
Yeah, absolutely. I mean, so Nick's right. I mean, there are a lot of systems in place, whether it be when you call 911 and the person, they have a system. The case management, the hospital has a system where they log in patients. We have our own systems, our own hospital interoperability, and we have our own software, and being able to connect all those systems together isn't easy. We're fortunate that we have expertise in that area for many, many decades. So we're good at doing just that, connect ourselves. But being able to take that and then innovate to basically not work as hard, let the software do the work for you, either through bots or through machine learning or AI, pattern recognition. And that's kind of the future, is to being able to first thing is kind of connect the systems together. So you have the ability to connect externally to different systems. So if, like, I'm working on a project with Kolby to connect a PCR to some of their hospital systems and using industry standards. So the Kolby's clinical team can validate or devalidate what they do in the field is meaningful, right? So you don't want to do anything if you don't really can make a patient impact. And some of the initial data that we run is really, really intriguing. You don't know what you don't know until you see the numbers in front of you, and it's unbiased, subjective things that we do and what it does to the patient, and it's all very exciting stuff that's going on right now. So being able to connect the systems is a big piece, but then also, so for example, we use our own. So ZOLL is a very robust billing software. We bill for a lot of Medicare, Medicaid things across the United States. And what we've done with our interoperability piece is use the technology from our billing platform to go out and look and see if we can find better demographic information and better billing information. So that means that you have higher quality work, you have actually less work in obtaining that information, because reimbursement's hard. So we'll try to leverage the technology to our advantage, and that's what we're currently doing now, which is that kind of interoperability systems, and that we can leverage ourselves. The security is always a thing. Like, everyone should be concerned with security, with data, and I'm very fortunate to have a lot of great people that we work with from our InfoSec team, who obviously manage our own internal security around the systems, but also help connect to large healthcare systems by maintaining very high level of compliance, really, that are industry standard across, whether it be HIEs or EMS or either health systems. And so investing, and it's not cheap, but you have to invest in that, those resources, so you can do the things safely, you can do it with the right patient at the right time. And so it's not just kind of throwing up a server in your little closet over here, right? You pay for web services, and you pay for the infrastructure to do that. The fact that we have it affords us the ability to connect to big health systems confidently. And then once we're connected, everyone wants to innovate. Everyone wants to not work as hard, right? To achieve a common goal. And that's where you have to use the standards, things like fires in HL7, use the NEMSIS standards to kind of connect multiple systems together. So as a system, you can not only just have a kind of a one-off, you have a system enterprise approach that everyone can benefit.
Yeah, the movement of data, that's been really a challenge, locally and globally, with EMS not being considered, a part of the system, although, we like to believe that we all are. When EMS transports a patient to a hospital, we generate a record that's electronic, and that electronic record typically turns into a fax electronically, and then it ends up in a medical records department in a hospital. That requires someone to remove that paper fax now, and then cross-reference it with the patient, find the patient in the system in the hospital, and then scan it and upload it as a PDF into the chart. When the technology exists to actually pull the significant or the specific data elements from the chart and have a landing spot within the patient's chart for a pre-hospital record. So it contains vital information for a patient that has had a stroke. We determine and document the last time that patient was known to be well and known to be normal. And then same thing with time-sensitive therapeutics and medications and such. So there are crucial informations. Greg did mention that it's important that they understand what was done by us, and that there's a smooth transition of data for and then cash out on the outcomes. Did those interventions like blood and blood products, is it making a difference for us to give it in the field, or is it causing more problems? And that's something that we'd like to know. And oftentimes when we talk to CMS about reimbursement, they want to know, are we improving outcomes? Well, you can't manage what you can't measure. And if we had that ability to collect that data seamlessly and across all EMS agencies and receiving hospitals, it sure would demonstrate, and we'd have much better information about what we are doing with outcomes and whether we're improving them or making them worse, which we know what way we're leaning as far as what we believe that we're doing. But it is a significant investment, and it's time and effort, and it's money. It's money to integrate with the health systems. So if you're traveling with your family, 3 states away, it's pretty easy to move your information around and get access to your information electronically. But if you were moved by an ambulance in your home state and then again in another state, you would never have access as a provider to that data. It would just be nearly impossible to get, which is unfortunate. But that's what we're trying to move along. And I know that there was a comment in there about innovation being stifled by poor reimbursement. Absolutely. It was always with great pride, that EMS can operate with a margin as these not-for-profits to be there for the patients, be reliable, be timely, and be able to invest in technologies and equipment and supplies that we feel is going to improve patient outcomes in the end. During COVID, Nick mentioned it. All of a sudden, EMS, there was no choice, right? EMS had to come to work, and we had to be innovative and creative about how we were going to protect ourselves while caring for others. And we looked for ways, and we moved with what the data was showing out of Italy. And initially, to protect providers, we were putting a breathing tube in everybody and putting them on a ventilator if we were going to fly them by helicopter, because it was really the only way to filter the air to protect the pilot, the nurse, and the paramedic. And it was believed to be best to ventilate the patient. And we quickly learned that patients that were on a mechanical ventilator fared more poorly than those that were not. So we were fortunate that we were able to identify a product by ZOLL Medical down in Texas. It was a big bubble that goes over their head, and it's called a ZOLL helmet. And they look like bubble guppies out there with these clear plastic bags. That's plastic housing, really, that allows the person to see, breathe normally, but it adds positive pressure and helps keep their lungs open and helps with oxygenation. And introducing that as a non-invasive technology, and then that naturally led over to individuals using high flow devices in the aircraft and in the ground ambulances. And we quickly found out how much oxygen it takes to power those devices, which challenged EMS, but we found ways to be creative and make it work and make it stick. But with high flow devices comes the need for humidification. And that's another need where it's a slam dunk. It's solved in the hospital, but making something like that that's portable, lightweight, and affordable and disposable in the pre-hospital setting has been a challenge. But Nick can probably speak to more of that too from the ground standpoint.
Yeah, I think one of the things that we're all sort of alluding to is, I think all of us in the pre-hospital space are trying to change the sort of old and maybe original concept of a 911 call, gets you an ambulance, gets you a ride to care. And that concept, I think we are challenging that concept. And really that 911 call, so the care starts when that dispatcher picks up and then starts to give you maybe instructions on CPR, or maybe instructions to give naloxone or not. And so that care starts at the time of 911 and then really persists all the way through to the hospital. And I think that's where folks like Greg are really instrumental as we become part of an actual healthcare continuum. And the reimbursement system, I don't think we're going to fix that today, but it is a challenge when innovation for long-term gains are the roadblock is the short-term cost, and that is something that we always have to work with. We really want to have improved patient-centered outcomes. We want to have improved accessibility to healthcare. We want more health equity, and it is sometimes difficult to bite the bullet and pay for whatever we have to pay for now to get those things in the long term, which are super important for both the system and those individuals. And so I think that's where, at the conceptual level, that we run into challenges, and that's where we have to work together and collaborate to try and get around those things.
there's been some success stories too that I've witnessed in my professional career where EMS has introduced new technology or new equipment that's been beneficial in the hospital setting. You know, when I started in EMS, we were using intraosseous needles that were inserted manually, and then powered devices came out, and they became rapidly proliferant. They proliferated rapidly in the pre-hospital setting, and to the point whenever they came into the emergency department, they're like, "What is this? Take it out!" And rapidly they realized the value in some of these devices that EMS were using to non-invasively or minimally invasively resuscitate patients. So before you know it, those IO devices were, you know, in crash carts throughout the entire hospitals. And same thing for supraglottic airways that are, you know, manually inserted airways that are blindly inserted airways. Same thing. EMS was bringing them in, and they're like, "What is this? Take it out." And then they slowly realized that was a bad idea, and that those devices work and they're efficient and they can be inserted rapidly by minimally trained responders. And they were beneficial to the patient, and they quickly found their way onto the crash carts too throughout all the floors within the hospitals.
Yeah, you know, to be feasible in the pre-hospital space, things really need to be, they have to be waterproof. They have to be basically bomb-proof, super durable. And so if you can build it for an ambulance, for a helicopter, it will work in the hospital every time.
Do you ever hear the term, if it's firefighter proof, right, then it can stand the test of time? And it's funny you say, Kolby, I remember putting in an EOA or an EGTA, and that was really pretty, it was very advanced whenever we were doing those a long time ago.
Yeah, I still read about those once in a while in the old textbooks, Greg.
Thanks.
I think it's great to be able to hear about the success stories of things that have worked within EMS and how they're then applied to within the actual hospital themselves. We have quite a few questions, especially around the different technologies and entering the markets, as well as what are some technologies that you guys would really need or want that might not be already in the pipeline already.
Interesting. For bringing things, you know, the question was about, you know, a specific device. If it's targeted EMS, you know, bring it to the folks at Medical Alley, and they'll put you in touch with us. We do have a lot of connections and a lot of outlets and we have seen the specific launch, but I think everyone on this call, as panelists, you know, we want to be a resource, and we would love to be able to trial devices that are here or that we don't know about yet. We do several labs, you know, a quarter. And so we have cadaveric specimens that we practice all of our surgical procedures and airway management procedures. And that's just how we get better. And we're always looking for a way to make high risk, low volume procedures lower risk and easily identified, right? And but beyond that, I mean, we are reached out to probably, you know, if not once a month, once every other month with the product, a similar product to something we already have. But it's all about quality and price, right? What value is it going to bring to the patient, and how affordable is it based on our flawed reimbursement structure? The question is a good one. Can we think of an economic arrangement with receiving hospitals that would benefit from improved pre-hospital care that would allow EMS to provide more interventions? And that's without the data. I mean, that's the challenge. But I think Greg's probably got a thought on this.
Yeah, it's a great question, and obviously you know, you can look at it from billing, a clinical, or an operation standpoint. So obviously billing, reimbursement, you need to make money to do it. You're not going to do anything if there's not a reimbursement, or there's not a patient safety, or there's not a compliance related thing. I think some of the things that would benefit EMS is what I call high data availability, and it's all based off scenarios. So if I go in a 911 and someone's unconscious, I'm not going to log into a system to see if they've got diabetes. I'm going to check their sugar, if their sugar's okay, or then we're going to take them to a stroke center, because, or a tertiary care facility. So I don't need, as a paramedic, I don't need to know certain things to take care of the patient in an acute setting. In a subacute setting, you talk about the scheduled transport. It would be nice to be able to go and look up, hey, this patient, oh, I see you've had diabetes, I see you're a doctor, you had a medication change last week. Are you compliant with that? Those kind of things. So in that case, you can help the patient navigate the system. They may not need to go to the hospital. As a provider, when I have time, I could actually call a doctor, run some ideas by that, call their physician, call a family member, whether it's medical or it's behavioral. We can have a whole side conversation about behavioral health and the appropriate destination. But the data availability to do those things is probably key. And one of the unfortunate things is CMS put out an ET3 project. I'll let either Nick or Kolby go, but they sunsetted it 2 years early, right? This December. And that was kind of the goal of emergency triage transport, was to basically get the patient to the right care, whether that be a clinic, whether it be a hospital, whether it be just to stay home, or there something, but not burden the emergency room with something that can wait. So, unfortunately, that would be nice to have some of the information to do a project like that. And hopefully we come back to that whenever I think we're ready. I don't know, Nick or Kolby, want to talk about ET3?
Yeah, so I mean, it really, I think the concept there was to think of 911 as healthcare instead of a ride. And so at the federal level, it was I think a great idea. The problem with it was, as we've discussed, there was, for those that participated, there was a significant short-term cost in administrative fees, in time and energy to make it work and make it feasible. So they didn't get a ton of participation, which I think is a large part of what led to them ending early. And so I have not seen where they said sort of what the next step is, other than the pilot is ending. So I don't know if they have enough data or what. They haven't really said. I don't know if Kolby, if you'd heard anything else about that, but the hope is that, yeah, we can take people to alternative destinations. We can maybe evaluate people, treat them in place, and then they don't have to, ride to the hospital, wait in triage for 6 hours, and then get the prescription and go home. And so I think the concept is a great one. I think it's a necessary one. And I'm still hopeful that maybe at other levels, at the state levels or other ways, we can consider those ideas, because I do think they're important. I don't know, Kolby, do you want to add to that?
Yeah, I think the key theme is that all emergency departments are at capacity, and there's periods of time where patients are spending more than 24 hours waiting to be not necessarily seen, but processed through the emergency department and determine a disposition determined, whether you're going home or getting admitted or just being observed. And with ET3, sometimes this is the EMS acting as the care manager in the hospital. Complex patients with limited resources oftentimes get assigned a care manager, and they help manage all their appointments that may be multidisciplinary. They might see a neurologist, they might see an endocrinologist, they might see a nephrologist. And those three types of that complex patient, seeing three different specialties, takes some managing. And for EMS to go out there and assess what is the issue today and is it an emergency, they can help make a phone call to the provider and determine, like, hey, we can see this person tomorrow morning, or this isn't so much an issue, but we do want to see them today, but we'll see them in the clinic. Or the less ill or injured patients can go to an urgent care, where it's a standalone center. Currently, the reimbursement model does not support that. The traditional transport, where we talk about a base response charge and mileage, that's always to an emergency department. And that's where ET3 came out, was to not backlog an emergency department. And then you think about mental health and substance abuse disorders and those patients, the emergency department is not a safe place for them. And the correct resources are not there unless they have a life-threatening emergency going on sometimes. So finding the correct outlet for that patient too, the correct disposition, which is oftentimes a very scarce resource. But when that patient can be redirected appropriately, that's how we kind of unburden our emergency departments for those patients that really need immediate life-saving care.
And Dawes, if I could go back just a little bit, there was an ask of sort of what advances do we need? I think that question is maybe harder than where are the pain points today? And I think if you go, spend an afternoon on an ambulance in a helicopter, with the people, with quote unquote boots on the ground, I think that's where it's quick to see these are some areas that we are frustrated, we have issues with, and the solution to that I think is harder. And in my experience, I would imagine in Greg and Kolby's, the solution ends up coming from conversations and discussions with people that often have nothing to do with the pre-hospital space. And so like one of the things that I think is going to change the way we approach cardiac arrest care, double sequential defibrillation has recently been published on earlier this year. And that was, okay, so we know that, people go into cardiac arrest and we shock them and it works well, but can we make it work better? And then taking some concepts from the electrophysiology lab of, well, what if we had 2 defibrillators and we put those on and we shocked people in quick sequence. I think those are the kind of things, at least when I think back to the last couple of years at Hennepin, ways that we've made changes were mostly not changes I expected, but were changes that came out of having, a psychiatrist come out with me and ride-alongs and talk about, what are our options for caring for patients that are experiencing a mental health emergency, and speaking with our addiction medicine clinic on ways that we can improve the care of our patients with opioid use disorder, et cetera. And so I think those kind of conversations are super critical to figuring out where that sort of next innovation comes from.
I think that's a really good segue, Nick. Actually, there was a question directed specifically to you, is how do you then, or how substantial is the effort for you to introduce a new technology, given the need for training and of course the supply chain management on the other end?
Oh, for sure. So I, at Hennepin EMS, there's the operations folks, which they deal with, budgets and FTEs and all those things. I'm the clinical oversight person. And so I can't really speak to the financial piece other than to know that when things have higher cost, it is longer discussion to make it happen. And, it depends on the issue. I think, one of the things that we recently implemented were our interpreter services previously existed, but they weren't ideal. And so, having seen this and lived this and worked with this for a long time, we ended up working with another company. We use Genie Interpreter Services, and we said, we can't wait on a phone tree and go through 6 minutes of, patient's name and et cetera, et cetera. We need to be able to just push one button and say, here's your interpreter. And so, the concept was great, and that didn't take a long time, but it was all the other back end pieces of, okay, well, this is a technology, so we've got to make sure we have the hardware to do so. We've got to make sure that IT has looked at the security aspects that Greg has spoken to. We've got to make sure that, everything's compatible, it's HIPAA compliant. And so those things sometimes can take a long time, years, but I think they are so important because we now have it today. And I think that just that simple idea of more accessible interpreter services has, although it's tough to document because we don't have a ton of outcome data, from what I can tell, it seems to be absolutely improving outcomes, improving health equity and accessibility, all the things that we are striving to do.
Yeah, one challenge, I think, when it comes to any device aside of cost, it's the capacity for introducing something new. Typically, we have our education based on our accreditations and our regulatory requirements. And those high-risk, low-volume procedures I talked about, that curriculum was built out for a year. So finding a place to finesse to meet within the capacity of our education team And it kind of comes with, how big of a bang are we going to get for the buck on quality, outcome improvement, how much is it going to impact the patient, to prioritize it within that mix, even if it's financially neutral, as far as a device.
Yeah, I guess I should add too, the training piece varies significantly from service to service. I've worked with really small agencies where you can get all the providers in one room on a Wednesday night and you can go over something and it's live tomorrow. And the bigger the agency, the less likely that is to happen. So for us, it usually takes about 3 months to start an educational process, get that through, and then make it live. And so that's kind of the minimum. And then depending on, we have educational sessions where we meet with every provider twice a year in the spring and the fall. And so if it falls around that, maybe we can happen right away. Sometimes it gets extended from that educational piece. That's an important piece.
Then you have to measure its efficacy. So is it impactful?
And I do see we do have some, oh, nice. I was going to say we have some folks raising their hands in the chat. If you're able to just submit the question, that's always super helpful as well.
I can answer one of them. The machine learning and AI and pre-hospital delivery is a really interesting topic. Of obviously at HIMSS, Health Information Management, the big conference, it's all they talked about was machine learning and AI, and we're already doing a lot of that in our dispatch product. So we can, obviously you can't pinpoint an EMS call, but we can look at the patterns, look at a lot of data, big data, and look at patterns and suggest things. So you can move different assets around. So you're not at an extended response scenario. So we're doing that now in our dispatch product, and then in our billing product, we have relationships with a lot of different third-party systems, and that's what allows us, our secret sauce, to go in and look at a lot of different data, and then look at patterns and then make suggestions. So and again, it's the infrastructure that the company I work for, ZOLL Data, has in place to be able to do those kind of things in a very efficient timeline. So if someone wants something, we can do a batch, do those processes, and then produce results to say, hey, listen, this is missing here, this is missing there, you can improve performance over here. But we have process in place, so we do that internally, that we help our customers to do that. Regarding the patient care itself, I mean, I think patient's a patient. Like they could, the problem with the patient is that they're always kind of trying to trick you. It's like, how many beers did you have? 2? Yeah, I don't know about that, right? How compliant with your medication? Yeah, I'm good, but then how come the numbers are all off, right? So the patient care side's kind of tough. I don't know, Nick, if you have a thought on that.
Yeah, I mean, I think the patient care and the impact of changes, thinking about data, thinking about, I see the next question's about TXA, and this is a conversation that I've had intermittently with Dr. Jay Gorlin over the years, and I think it used to be that I understand that the data for trauma shows that if we quote unquote stay and play, we're likely to have worse outcomes in trauma. And so as we thought through, should we use TXA at Hennepin EMS, our transport times are much shorter than if we're out in greater Minnesota. And so we took a stepwise approach to, is this a good idea or not? Because what we didn't want was to use TXA because it's a cool thing, but then have our scene times increase significantly and then ultimately decrease our patient outcomes, have our patients have worse outcomes. So, the first thing we did as to looking at the data we do have is we looked at our transport times with actual numbers and said, what's our actual average transport time, just not what we've always been told, but what's the actual number? And then we used a small group of our paramedics to do a pilot and say, okay, if we train on, use this medication when you can, but do not increase your scene time, don't stick around just to do this. Can we do that? And that small group did. And then we were able to expand it to the entire service. And because we do understand from the CRASH 2 data that early TXA has an impact on mortality. And so taking all those things together and then implementing it and then going back later and saying, all right, now if we look at all of our critical traumas, what's our average scene time? And then if we include the ones, now we're just going to look at those that get TXA. to those ones that get TXA, are we staying longer on those scene times? Because that would indicate that we need to maybe address education or reconsider if this is a good idea. But there are a lot of steps along the way, especially at a service like ours, where we, in service like Kolby's, where transport times are an hour or two. I think it's obvious. I think it's in those more urban settings where there's lots of different hospitals where it was less obvious for a medication like that. I don't know if Kolby or Craig, if you guys want to add to that.
Yeah, we're seeing TXA. So for those that aren't aware, TXA is to help with the clotting process in major trauma or major hemorrhage. And there was a lot of studies done in the military with it. And so they had thousands of patients in the studies. So like Nick said, it's earlier on the better, but it's one of those things, all the priorities you have to do versus the time that you're spending with that patient encounter. It's something that we typically do once the patient's on board and we give that medication en route in conjunction with the blood. But yeah, it depends. There's a different practice all over the country. Like I said, Minnesota really leads the way when it's the complexities of what we put in an aircraft or an ambulance, and I would say the level of care that we're bringing to the bedside, whether it's a 911 response in town or in rural Minnesota, or if it's transporting a patient from a community hospital or from one tertiary care center to a quaternary center that's a specialty center like burn or hyperbaric therapy. Those are sometimes the most complex patients. There's a question there, are there problems with the design of the ambulance or the helicopter? It's always size, right? And for helicopter, everything, it's not only physical size, it's weight. Every kilogram matters that we have in the aircraft because it's one less kilogram of a patient we can carry. We stuff everything in that helicopter that can cover the gamut from, a newborn baby, up to the most complex patient with multiple comorbid factors. So when we lift off, we never know what we're going to. So we have to be prepared for all those, at all times. So a lot of times things ride along for, several months without having a use. But when you need it, you need it. So I'll let Nick address the ground ambulance side. But for air, it doesn't matter who you are. It's the space in the aircraft and limited oxygen sources really, and gas, right? Fuel. That's our biggest limiting factor, weight and fuel.
Yeah, so we have space limitations, but not quite like a helicopter. I mean, you can see the ambulance behind me is spacious compared to the cabin of the helicopter. And so I think we have similar limitations. I think Kolby sort of alluded to one of the things that, when I started my emergency medicine residency, I was under the impression that in the emergency department, we have the most undifferentiated patients that exist, which in the hospital is true. But, when we arrive on scene as a ground crew or an air crew, we hope to find a human being, and that's often the most reliable information that we have. We don't have their past medical information, their last echo. We don't have their most recent CT scans. As Greg had mentioned, we don't even know if they have diabetes. We know we can check a sugar, we can check vitals, we have what we can see. And so having things that are not only interoperable between different systems, but also as applicable to as many patients as possible, I think is really critical. When we look at different airway devices over the years, one of the things that I really didn't want was okay, so adults are going to get this airway device, and then if we get into babies, that's this airway device, and then neonates are this airway device. I really like, for simplicity, to quote unquote keep it simple. I think that concept is important as we think about devices and patient access, patient care, because the last thing I want is a medic, and medics in the US, if you look at averages, do 1 to 2 intubations a year. I don't want them doing their second intubation of the year on a newborn baby with a device they've never used before. I think it needs to be something they're used to. It needs to be kind of the same way every time. And so when I think about conceptual pieces for technology, those are the things that really stand out for me. I don't know if Greg, you want to add to that?
Yeah, I mean, the I think the root question is you need the right device at the right time, or you need the right data in the right time. Like, I'm not interested in someone's medical exam from 2 years ago, or their lab from 2 weeks ago. You know, I need what I need to know right now to do the things we need to do to get them to definitive care, or to make to help with working with a medical director to make an informed decision that they are low risk, that they're okay to be left at home with family or by themselves. But at the end of the day, you still need the data, the right data at the right time to make that decision. And if I'm on scene, I can't be sorting through like pages and pages and pages and search and having to look at different things. Like, and that's kind of the challenge now, from a subacute standpoint. And then the same thing goes to the hospital. So we transmit all this information to the hospital, but what is the right information for a doctor, right? So that this is coming in, there's a lot of stuff going on. If it's a very, very sick patient, and they can't be sorting through all these different pages and pages of notes from EMS. So like as a person, so I used to work in an emergency room as well. And so you come in, like, what was the last known well time? Did you check our sugar? You know, what I need, like, give me the cliff notes here so I can continue on what you've done and not have to repeat or miss what was not done in the field. So that's the challenge, right? How do you who helps make those decisions? So we work with great people, CMIOs, chief medical information officers, or CISOs, medical directors who have that practical knowledge of the receiving clinician, of what data is important, and then be able to measure that and make a difference in the patient's care.
And as we're coming up on the 2-minute mark, I think it would be a really great opportunity to kind of hear what your all's kind of closing remarks are, as well as like pass forward and where we can kind of go and take it from here.
Yeah, I would say number one, consider us a resource, those in this call. And if we don't have the answer or what, we'll direct you to somebody that does or can assist, with your product or with your questions or thoughts. And I would encourage you to seek to understand your local EMS agency and the structure of it. And because I think if you pay attention to the news, EMS is really it's a fragile framework right now, and funding is going to be more and more of an issue every day. And like I said, consider us a resource, and I really appreciate you taking the time to learn about something that's not often talked about, especially with the medical alley. So this is a great opportunity. Yeah,
I would say go for a ride. Call your local EMS. 4 hours, 8 hours. Try to ask for a busy day and go see what it does. It's eye-opening when you go into people's houses and learn. And there are some very, 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 very smart people in emergency medical services, and who have a passion for healthcare and people. And to understand that, to help bring all the systems together, whether it be medical, whether it be technological. So ask.
Yeah, I just want to echo those comments. And, I'm actually really excited for the future, knowing that, change is hard, but I think the future of where pre-hospital care is going is an exciting place. All these ideas from the federal level down to the very hyper local level are exciting to me. And I think it's great that more people, including those on this call, have an interest in that pre-hospital space and how we can, reach our patients earlier in, like I said, a more accessible way, improving health equity. I think those sort of things are going to lead the way in healthcare, especially as, we've already mentioned, the hospitals are full, the nursing homes are full, everywhere's full. And so I think we are sort of, in a way, being forced to think about how can we achieve some of those same care ideas in a different way. And so I'm excited to work with folks on this panel, the folks on this call, as we reimagine sort of what that looks like in the future.
Well, I'd like to thank each of you guys, Greg, Kolby, and Nick, for sharing your insights with us. And again, we also want to be sure to thank our sponsors for helping sponsor this webinar series. Of course, before we let everyone go, I just want to make sure we remind you guys of other opportunities to be able to network with, whether it be folks on this call or outside within the Medical Alley community, at 2 events that we have coming up in September. The Alley Chats event, which is our kind of signature networking event. That will be hosted at Target Field as well on September 26th. We have the Equity in the Alley Women to Watch featuring Kate Stewart from Stryker and their ENT arm. So thank you guys all for joining us today. Have a great day in Medical Alley.